Hello, everyone, and welcome to tonight's webinar, Identification and Early Management of High Risk Factors in Pregnancy, brought to you by the Capital Health Network and obstetrician gynecologist, Dr. Omar Adham from the Canberra Health Services. So first, we would like to acknowledge the traditional custodians of the land we are meeting on. We acknowledge and respect their continuing culture and the contribution they make to the life of this region and pay our respects to their elders past, present and emerging. We would also like to acknowledge and welcome other Aboriginal and Torres Strait Islander people here today and acknowledge their contribution to the society and their ongoing future. I'm Dr. Leonie Harcourt, the GP advisor at Capital Health Network. Also with me tonight is Dr. Omar Adham and Kunal from the Capital Health Network. So tonight we're going to do things a little bit differently than we have in past webinars, and we're going to have questions at the end of each session. So the talk is broken up into 3 major topics and 1 minor topic. So the first topic is obesity, and then we'll be talking about hypertension and preeclampsia. And lastly, prevention of preterm labour, and with a little bit of gestational diabetes on the end. So we're going to ask you to put your questions into the question and answer box, and we will run essentially 4 Q&A sessions rather than one big one at the very end. The other thing that we're doing differently tonight is in terms of CPD points. So all participants will be sent out a certificate of attendance, and you're very welcome to self-report onto your CPD home the 1.5 hours of educational activities. If you'd like Capital Health Network to upload your CPD to the RACG CPD home, please send us your RACGP number and your surname and a completed non-identified evaluation form. So we can do it for you as well, but you're also very welcome to do it yourself to self-report once we've sent you the certificate. So all the presentation will, of course, be on the Capital Health Network YouTube channel, and we can also send out the presentation slides to you as well if you'd like. So without further ado, tonight's presenter is Dr. Omar Adham, and he's a skilled gynecologist currently serving as a senior gynecologist at the Canberra Hospital. His area of expertise is laparoscopic surgery and surgically complex endometriosis and urogynecology. He's also made significant contributions to clinical research and teaching. Dr. Adham also operates a private medical practice providing comprehensive obstetric and gynecological care to a diverse patient population. So thank you very much and welcome, Dr. Adham.
Thank you, Leonie. Good evening all, and thanks for joining in tonight's presentation. I'd like to acknowledge the effort that Dr. Leonie and Kunal had went through to bring those presentations together, and I hope this will add to our learning tonight and will take something good out of it. So I'll start. The presentation is about identification and early management of high risk factors in pregnancy. We're going to be targeting obesity and pregnancy, and also risk assessment for gestational hypertension, preeclampsia, gestational diabetes, and preterm birth. So obesity in pregnancy is, as you are all aware, identified or defined as maternal obesity for BMI above, equal to, or above 30. There are significant complications that are associated with obesity and pregnancy. And I have divided those into fetal complications, maternal complications, and also obstetric complications. I will talk about fetal complications first. So we recognize there's a higher risk of congenital anomalies in the babies of the morbidly obese patients, particularly neural tube defects. There's also a very common occurrence of fetal macrosomia and an increased risk of stillbirth. The maternal complications include gestational diabetes, pregnancy-induced hypertension, thromboembolism, obstructive sleep apnea, maternal death, and depression. And the obstetric complications include miscarriage, first trimester and second trimester miscarriage. There is an increased risk of induction of labor, an increased risk of cesarean sections, and particularly complex cesarean sections. Also a higher risk of instrumental deliveries, which includes forceps deliveries and ventouse deliveries, shoulder dystocia, postpartum hemorrhage. There's also anesthetic risks and an increased risk, increase in ICU admissions. So the current recommendations from our college, the College of Obstetricians and Gynecologists for Pregnant Obese Women, includes the following, and I'll touch base on each. So the recommendation is if you're a clinician who had booked the patient in, or a primary care provider, is to refer to a health facility with a multidisciplinary team, which is more of a collaborative care involving obstetricians, dietitians, endocrinologists, and we also have exercise physiologists and so on. And that main unit is placed at the Women's Health at Canberra Hospital here in the ACT. High dose folic acid is recommended at 5 milligrams once daily earlier on in pregnancy, and that's to reduce or prevent the neural tube defects in the fetus. So as I mentioned earlier on, there's a higher risk in the obese population. Calcium and aspirin to reduce the risk of pregnancy-induced hypertension, preeclampsia. So that's to be initiated at 12 weeks and continued until 36 or 37 weeks approximately. There's very good evidence to support both calcium, 1,500 milligrams to 2,000, and aspirin between 75 and 150 milligrams. And we'll talk about the benefits of each later on. Also, an important thing in terms of rapid weight loss in surgery and pregnancy for that particular cohort of patients. Recent rapid weight loss for those patients, the recommendation is to avoid pregnancy during that period, as it can have got a substantial impact on the baby and the mother. First trimester screening, which is the non-invasive prenatal testing and the risk assessment in the obese population, the results can be limited. So when they're offered, it's important to discuss the potential for inconclusive or limited information. And for those who attended the prior webinar, if you do recall, that was due to a reduction in the fetal fraction for the NIPT test and the maternal blood, and that's quite crucial for accurate result reporting. Can't emphasize the importance enough of COVID and flu vaccinations. We have had some very, very significant adverse outcomes in terms of pneumonia in the morbidly obese patients. So it's strongly recommended that they do have those. Also, a GTT at 16 weeks is recommended, and a repeat at 27 to screen for gestational diabetes. If they can't have a GTT because it's not the most pleasant test, then an HbA1c at booking would be equally good. Fetal growth monitoring, we know there's an increased risk of macrosomia, but what's more alarming in those is if we actually get a growthly restricted baby. Serial ultrasounds to monitor the growth and the well-being involves particularly the morbidly obese, so BMIs probably above 45, where it's really difficult to clinically measure the fundal height. So we have no idea, what sort of growth pattern that baby is following. Thromboprophylaxis is recommended for BMIs over 45 at booking. due to the increased risk. And it's also important to have an understanding as a primary health or care provider for those patients, because they really, we see a lot of them have a lot of confidence in their GPs. So when they look at VBACs or vaginal birth after cesarean section, the general practitioners have a fair bit of input into this, and it's good to know a bit about it. Now, VBACs in the low-risk population, so those who have a normal BMI and have had a cesarean section for fetal distress previously, they have no contraindications to a VBAC. The success rate is about, the literature quotes, 85 to 90%. Our experience is about 70 to 85%. And each and every time there's an additional risk factor added to their current pregnancy, that brings that percentage down to a halt substantially. So, you know, an induction would take it from 75 to probably 35 or 40, you know, if the baby is growthly restricted, macrosomic, and particularly if she has a high BMI. The BMI is a key driver in those, and the VBAC success rate is much lower, and the complications are higher. Induction for BMIs that are above 50 is recommended, and that is because of the increased risk of fetal death in utero and stillbirth. Now we can stop here and take some questions about obesity in pregnancy if you have any. Otherwise, I'm happy to move on to the next subject, which is risk assessment for preeclampsia, understanding and prevention. Leonie, to you.
Yes, we had a question in the chat box. Can I just get everyone to put their questions in the Q&A box? And it was about when do you test for GDM? But I think you're going to get onto that later on in your talk with people with a family history of GDM. Or
yes, correct. Yeah, I'll talk about risk factors. Absolutely.
Yeah, I was just wondering. I had a couple of questions, if that's okay. So the thromboprophylaxis for people with a BMI of greater than 45. So obviously you wouldn't do aspirin and thromboprophylaxis, would you? So you
yeah. So that depends. And again, that's a very good question. The aspirin is for a different purpose, I suppose. It's for risk reduction of preeclampsia and hypertension, and that's the most recognized antiplatelet agent that yields good risk reduction. So they looked at, there were studies in this about heparin and clexane for risk reduction of preeclampsia, and we don't have a lot of evidence. So the answer to your question is yes, we would. If aspirin, particularly for BMIs over 50, we do combine aspirin and prophylactic clexane for thromboprophylaxis.
Okay, great. So there's a question from the audience, and that was my understanding was FMU was now advising only 1 milligram of folic acid for high BMI and reserving 5 milligrams for people with a history of neural tube defects and epilepsy medication. I think it was due to the increased risk of gestational diabetes with high dose folic acid. Are you aware of that change?
No, no, I'm not, but I'll probably look into it. The fetal medicine unit has had a lot of changes in staffing, and I'm not quite sure. I think we had some people come down from Sydney and run it. And now we've got our local FMU specialist back on board, but I'm more than happy to check in with them. So far, we've been recommending 5 milligrams. I think in my experience, the risk of gestational diabetes is quite substantial in that particular group of patients, and I don't know if you know, a slightly higher dose of folic acid is going to be the driver in that
Yeah. I just had one other question, and then we can go into the next one. I wasn't aware of this multidisciplinary team for managing obesity in pregnancy at Canberra Hospital. Is this a new thing, or?
No, we had well, so we had a special clinic. We called it the bump clinic, which is basically for the obese population. So it was a clinic run specifically for the obese patients.
Yeah.
And then we were very short-staffed for the past 2 years. And so that clinic disintegrated. And now, unfortunately, those patients are spread out through most of our sort of low and medium risk antenatal clinics. But what I was referring to is we still have the infrastructure in place. So we still have, obviously the obstetrician, we have the dietitians, the exercise physiologists, and we have our endocrinologists, and we have our obstetric physician. So they're all the same place.
Is that something that GPs refer to, or is that something that once they're in the maternity kind of unit?
We triage them.
Yeah.
Yeah. So you refer them when you recognize, when you've got a patient, just refer them to the antenatal clinic, and we do a risk assessment and then triage or allocate those patients accordingly.
Right. Okay, great. Okay, thanks very much. So we will move now on to the preeclampsia part of the question. And please remember, type any communication into the Q&A rather than the chat box. That'd be great. Thanks very much.
All right. So the next subject would be the risk assessment for a very common condition, particularly in our community, of gestational hypertension, preeclampsia. And the intention is to have a bit of understanding about that and the prevention strategies available. So the risk factors for preeclampsia include prima gravida, so first pregnancy, the extremes of age, so the very young patients below 20 and the patients that are above 35, so that's advanced maternal age by definition. Obesity is another risk factor. Chronic hypertension, so pre-existing chronic hypertension or renal disease, multiple gestation, family history of preeclampsia, and a previous history of preeclampsia, which is the most important risk factor, and pre-existing diabetes or autoimmune disorders such as antiphospholipid syndrome. And we're going to divide those into moderate risk and high risk. So because it determines who gets aspirin plus minus calcium. So if patients score 1 high risk factor, then they automatically are recommended aspirin. And those with moderate risk factors, if they score 2 of those, then they will be recommended to consider or encouraged to consider aspirin antenatally. So the high risk factor group includes personal history of gestational hypertension, preeclampsia, or HELP syndrome in a prior pregnancy, chronic hypertension, type 1 and 2 diabetes, chronic renal disease, and autoimmune disease such as SLE and antiphospholipid syndrome, and the IVF patients with a donor egg. The moderate risk factors would be advanced maternal age, over 35, prima gravida, if there's a gap of more than 10 years between both 2 pregnancies, multiple gestation, and low socioeconomic status, also personal history of prior low birth weights, IUGR and FDIU, a family history of preeclampsia, first degree relative, the mother or the sister. So if someone is over 35 and they've had a baby that weighed less than 2.5 kilos at term, then they obviously qualify. there was an unexplained FDIU, and multiple pregnancy or a family history, they automatically qualify. Sorry, this is when I was really exhausted. I couldn't put this more delicately. So just wanted to look at the recurrence risk in subsequent pregnancies for gestational hypertension and preeclampsia. So you can see that previous gestational hypertension subsequent pregnancy carries a significant risk of anywhere between 16 to 47%, and a risk of preeclampsia of 2 to 7%. If they have had preeclampsia in their first pregnancy, then they have a similar risk for gestational hypertension, but obviously a significantly higher risk of preeclampsia. It's up to 16%. And the risk of preeclampsia in future pregnancies depends on the severity of preeclampsia in the past pregnancy. So the severity of preeclampsia is dependent on the gestation where they develop that. So the earlier the gestation is, the more severe the preeclampsia is deemed and the higher the risk is. So someone who has had prior preeclampsia prior to 34 weeks, they have a 25% risk of preeclampsia. But those who have had it prior to 28 have up to a 55% risk of recurrent preeclampsia in subsequent pregnancy. So I'm going to sort of talk about what prevention strategies do we have for preeclampsia, and it really comes down to aspirin. So aspirin was one of the antiplatelet agents that was studied, and with that we looked at clexane and heparin, and aspirin had the most benefit. And to understand how it works, I thought we'd touch base on a little bit of pathophysiology of preeclampsia. So what we previously identified is an imbalance between the circulating prostaglandins, the prostacyclin, and the thromboxane. And the aspirin corrects this imbalance by inhibiting platelet aggregation and dilating the blood vessels. There's been some also recent studies that looked at the anti-inflammatory effect of the aspirin, and it seems that it's also adding to its mechanism of action. So aspirin for preeclampsia risk reduction in moderate and high risk patients. And the reason I say moderate to high risk, because there's no evidence to support prescribing aspirin for the low risk population. It doesn't work in terms of preeclampsia prevention. So we know it has a aspirin in the moderate to high risk population has probably a 15 to a 25% preeclampsia and gestational hypertension risk reduction, but it also has a 14% reduction in stillbirth and neonatal or infant death. It has a 10% risk reduction in small for gestational age infants. And it's interesting, and this will explain why it's indicated for the moderate to the high risk group, because in the moderate risk group, you need to treat 114 patients. That's the number needed to treat to prevent one case of preeclampsia. But in the high risk group, you only need to treat 50 patients. And so low-dose aspirin is indicated for women with at least moderate to high risk of preeclampsia, i.e. secondary prevention for preeclampsia in women at increased risk and in women with significantly increased risk in their first pregnancy. So that's referring to the moderate risk and the high risk. In most cases, we tend to cease aspirin in about 37 weeks. There's no scientific evidence, so it's not based on any of that. And it can be happily continued up until term. All you need really with the aspirin is about 6 hours prior to delivery. So the anticoagulative effect of it sort of dissipates. Calcium supplements, I was going to touch base on that as well. it has been demonstrated to significantly reduce the risk of preeclampsia, particularly in the high-risk group, and in those with low dietary calcium intake. Now, I don't really screen their diet. We don't really have time to do that. So, and no harm comes from calcium supplementation. So I generally prescribe it to all my patients, about slightly on the lower dose, 1,500 milligrams plus aspirin earlier on in pregnancy. It's interestingly, calcium has also been demonstrated to reduce the risk of preterm birth, but it doesn't have a significant effect on reducing the adverse fetal and neonatal outcomes, which including low birth and fetal growth restriction, stillbirth, or death. And remember, aspirin does that. So a dose of 1.5 grams per day would be reasonable to offer that for women with moderate to high risk of preeclampsia, particularly those with a low dietary calcium intake. And just sort of touching base on each of those alone. So as I said, there's strong evidence for calcium supplementation, is about a 40 to a 50% risk reduction in patients. And the studies have been mixed. So they look at low calcium diet, and that just depends on what your definition of that is. Also aspirin, 75 to 100 milligrams per day. Ideally, we start between 12 to 16 weeks and continue until delivery. Commencing aspirin after 26 weeks is of no use. Women inquire a lot about vitamin C and E, and there's been some very clear evidence that there is no benefit in preventing preeclampsia. So we'll stop here, Leonie. Again, happy to take questions.
Fantastic. Yeah. So I think one of the first question is, what gestation do you start aspirin? But you've already covered that. And you also mentioned in your previous webinar about a low PAP-A and aspirin. So
sorry, I forgotten to put this in the slides.
Yeah, so maybe just a little bit of a talk about that. That would be great. And then there's a couple of other questions as well.
Yeah. So in the first trimester screening, it's a combination, obviously, of an ultrasound that looks at the fetal nuchal thickness, and we also test some maternal biochemical markers, and one of those is the PAP-A. And we do a risk assessment and adjustment that looks at, one, the common fetal chromosomal abnormalities like trisomy 21, 13, 18, but we also provide a risk assessment as to the for preeclampsia, IUGR, and preterm labor based on the maternal serum biochemical markers, which includes PAP-A. So a low PAP-A is the level identified below 0.4, and the lower it is, basically, the higher the risk is of those conditions I mentioned. So a recommendation to start or commence aspirin from 12 or 13 weeks would be if your PAP-A is below 4. What was the other question, Leonie? Sorry. Leonie, I think I lost you.
Sorry about that. So the next question is there any alternative to aspirin if anaphylaxis to an NSAID?
No.
Yes.
Not that I know of.
Right. It's aspirin or bust.
That's right.
Yeah. And then we've got another question. Are there any partner, baby's father or the sperm provider, issues that increase or decrease risk for women?
For preeclampsia?
Yeah.
Yeah, not that I'm aware of.
Yeah. And then a further question is, has magnesium been researched in the prevention of preeclampsia?
Yes, I think there are a couple of good randomized controlled trials. So magnesium oral supplementation you're talking about?
Imagine. Yeah, I imagine. Yeah.
Yeah. So I think I may have encountered a couple, and there was no conclusive evidence that there is a clinically significant risk reduction for those who do take it.
What about vitamin D? I've heard that sometimes vitamin D can help with the placenta implanting. So does the vitamin D deficiency have any implication for placenta health?
Yeah, look, I don't know if I can make a credible comment on this, but not to my knowledge. Again, it would have been something we have looked at and recommended routine vitamin D supplementation. But I may have come across that at some point, Leonie. So I'll have to have a look at that and get back to you.
Sure. Okay. We might move on to the next section. Thanks for all your questions, everyone.
So I just wanted to mention, talk about diabetes in pregnancy, screening for diabetes, identifying risk factors. There's not a lot of preventative measures that we can implement aside from, pre-pregnancy counseling with lifestyle adjustment and weight reduction and optimizing, those who have got pre-gestational diabetes, sort of type 1 and 2. But the risk factors for developing gestational diabetes in pregnancy would be advanced maternal age. We all agree BMI is over 30 and pre-existing type 1 and 2. Previous gestational diabetes or a baby that was macrosomic and, weights that are above 4.5 kilos. That's another risk factor, because that sometimes tells us that we may have actually missed or we may have had a false negative GTT potentially at that pregnancy. Polycystic ovarian syndrome is a risk factor. An ethnic origin, so Aboriginal, Torres Strait Islanders, South or East Asians and Africans are considered at risk, at a higher risk than other ethnicities. Migration, so being a migrant rather than a native, increases the risk, and that might be something to do with stress, I suppose. I couldn't think of anything else. And so if we do identify any of those, then recommendations for GTT at 16 weeks. If that was declined, or if the risk factors were identified earlier on, then an HbA1c at booking is equally fine. And then we will move to preterm birth. So if anyone has any questions about that very short part of the gestational diabetes discussion.
There's actually a question here. So when do you recommend to do GTT if RBS high in first antenatal blood workout? So random blood sugar is high in the first antenatal blood workout around 5 to 8 weeks.
Yeah, I do it immediately. So anytime you get a fasting that's abnormal or an HbA1c, then I do a GTT. So if they're 5 weeks, 6 weeks, or 7 weeks. And there's some evolving good evidence that treating, they may, if they do require, so getting onto that and initially approaching that conservatively with testing, and then if they did require insulin or metformin, treating it at early gestation is beneficial.
And so the information around metformin being continued throughout pregnancy, is that something that's changed in the past few years, hasn't it?
I think it's changing. It's evolving. So now if we get type 2 diabetics or metformin dependent, we'll have them continue that in pregnancy. That's something very recent they're doing. I mean, I'm not obviously an endocrinologist, but as part of the multidisciplinary team, I've seen that a fair bit most recently. Still, I think the recommendation is to withhold it. And sometimes the level's correct in pregnancy, and at other times they don't. And our preference is to manage with, obviously, the likes of Prolafane, which is long-acting, and Actrapid, the short-acting, because we can control that a lot easier.
Yeah.
Yeah.
There's some women with polycystic ovaries who go on metformin to kind of get ovulation happening.
Yeah,
And I was under the impression that they would stay on it for the first trimester.
correct.
Is that still the case?
Yeah,
Yeah.
yeah.
Yeah. There's one other question just pertaining to I think the obesity part of your talk, and it says in New South Wales there is Get Healthy in Pregnancy service, which helps women gain healthy weight in pregnancy and thereby reduce risk for them and the babies. Does the ACT offer a similar program? I guess maybe the multidisciplinary team with the dietitians and the exercise physiologist was that kind
Absolutely
of.
correct. Yeah, we don't
Yeah.
have a
Yeah.
specific program, unfortunately, not
Yeah.
that I'm aware of.
Okay. We'll move on to the next part. Thank you for that.
So, preterm birth is defined as delivery prior to 37 weeks of gestation. It is a multifactorial condition, so there's a lot of factors that sort of come together and a lot of risk factors for it. It is recognized to be the leading cause of neonatal morbidity and mortality. That's why there's been so much emphasis on identification and management of risk factors, because some of those preterm births are preventable. A short cervical length found on a morphology scan, which is obviously routine screening here in Australia between 18 to 20 weeks, is one of the most critical predictors of preterm birth. So important to pay attention to that. And as I said, identifying that particular cohort of patients will allow us to have the opportunity to treat and prevent potentially some of those preterm births. So identifying risk factors, the maternal risk factors, the most important predictor is a previous preterm birth, a mid-trimester loss in particular, and again, premature rupture of membrane. So that's the most important thing we need to pay attention to in their obstetric history. Multiple pregnancies are at risk of preterm birth, as we all know, and certain uterine anomalies, such as uterine didelphys and uterine septi, cervical trauma, and I'm referring particularly to repetitive loop excisions for cervical dysplasia, and also cone biopsies. The cone biopsies carry a significant risk of cervical incompetence and pregnancy losses and preterm birth. Maternal demographic factors, so maternal age, extremes of age again, so below the age of 17 and above the age of 35, race and ethnicity, and that's complex, and low socioeconomic status. Lifestyle factors, so smoking, we know is associated with preterm birth, and substance abuse. Chronic stress and mental health is another recognized risk factor, and malnutrition and weight management. Again, the extremes, the obese and the malnourished patients. Maternal medical conditions, so diabetes, poorly controlled diabetes increases the risk of preterm birth. Unsurprisingly, hypertension, so preeclampsia and preterm birth, there's a connection there. Maternal infections like urinary tract infections, dental infections, bacterial vaginosis, and so forth, if they were untreated, can lead to preterm birth. The patient's reproductive history, so her current pregnancy, and we'll talk about those in more detail. So if a short cervix was identified in the mid-trimester and the cervical length is below or less than 2.5 centimeters or 25 millimeters, that's a strong predictor. Pregnancy spacing, so short pregnancy intervals between pregnancies is a risk factor, and cervical incompetence. Prevention strategies. So it's important to understand that preventing preterm labor is a multifaceted approach, and it involves addressing various risk factors and implementing targeted interventions. So it's not just about progesterone, if they, smoking and weight management and a few other issues needs to be dealt with simultaneously. So this management, there are 3 management pathways that are implemented in for short cervices identified at morphology scan. And this is not an uncommon encounter. It's actually quite common where you have your patient present at 20 weeks, you ordered a morphology scan, and it depends where it was done. Obviously, tertiary levels try and implement universal cervical length measurements because it's a very good tool to use to screen for cervical incompetence and the risk of preterm birth in the current pregnancy. So if you were faced with one of those, then you have 3 options. And that depends on the patient's clinical background, what other risk factors she has. Is she classified as being on a high risk or a moderate risk patient? So there's a conservative approach, which is cervical length surveillance via transvaginal ultrasounds. There's a medical approach with progesterone, and we'll talk about that. And there's a surgical approach with a cervical cerclage, and that may be a rescue emergency cerclage in the current pregnancy, or it might be an elective cerclage that's put in prior to her becoming pregnant. GPs are involved in the antenatal care of those women, and you may have to counsel them about that if they present to you first to talk about options. So this is the current our college, the College of Obstetrician and Gynecologists for Australia and New Zealand. There's a consensus-based recommendation that as a health provider, if you're involved in that woman's and the patient's obstetric care, if you do identify a short cervix that is less than 25 millimeters on a transvaginal ultrasound, because our cutoff for the transabdominal is 35. If this was picked up at 18 to 24 weeks gestation, it requires management. So we are actually accountable. So what do we do? These are the prevention strategies. So we'll talk about progesterone supplementation for the high risk group, made it recognized to reduce the risk of preterm birth. Cervical cerclage, basically it's a mechanical reinforcement to a dilated and short cervix. And it's all about tying a purse string around the cervix to try and hold it together. That's pretty much how we do it. And it's, again, about timing. So there's a cutoff, 23 weeks and 6 days. And patient selection. So it's about the type of the suture we put it. So there's different types of cerclages. Transvaginal, sometimes we do laparoscopic ones for different reasons. Education and counseling is quite important, obviously, raising the patient awareness, particularly about any potential symptoms or red flags for preterm labor. Recognizing those and seeking immediate help would be quite important. And collaborative care, what it's all about. So, involving the general practitioners, the obstetricians, the midwives, and so on. A coordinated approach for a good outcome. And then personalized care. So the approach, particularly for cervical cerclages, is all based on the individual risk profile, as I mentioned, and it's a multidisciplinary team. So again, when someone is referred to the tertiary hospital here at Canberra Hospital, they either present electively if they've had a poor obstetric history of, recurrent mid-trimester losses, and then they'll be reviewed by FMU, and a decision will be made as to whether or not they're suitable candidates for progesterone prevention or cerclage, and then they'll approach the surgeons who do the cerclages. And so there's sort of a group decision. Now, just as a general statement, offer the choice of a prophylactic vaginal progesterone pessaries or cervical cerclage to those women with a current short cervix that's less than 25 millimeters, with a history of a spontaneous preterm birth prior to 34 weeks or a mid-trimester loss. I'll talk about that in more details because it's sort of not a very specific statement, but it is by our college. Talk about progesterone supplementation. So progesterone has been recognized to be quite important in the maintenance of pregnancy, particularly as we know in the luteal phase, and it also prevents uterine contractions in the second and third trimester. So the high-risk patients, particularly those with a history, again, of preterm birth, extreme prematurity, or a short cervix, will benefit from progesterone supplementation. It can be given vaginally, as in suppositories, orally, or in injections. In Australia, we give it vaginally. Progesterone supplementation, it certainly has been shown to reduce the risk of preterm birth, also by supporting uterine quiescence. So again, so that's the dose that we use in Australia and New Zealand. So suppository of 200 milligrams daily until 36 to 37 weeks gestation. Go back and reinforce indications. Asymptomatic women with a current short cervix, less than 25, on a transvaginal scan in mid-trimester. So that's an ultrasound and morphology scan done between 16 to 24 weeks. Women with a singleton pregnancy with history of previous spontaneous preterm singleton birth prior to 34 weeks or mid-trimester loss. The shortened cervix in pregnancy. So this is if you were faced with finding of a short cervix. We'll talk about this in terms of it certainly significantly elevates the risk of spontaneous preterm birth, and identifying this particular group provides an opportunity to reduce that risk if we can manage it. Wanted to talk about routine cervical length screening. So globally, it is, particularly in Europe and the United States, it's routinely done. It's an opportunity because 99% of our patients will end up with a mid-trimester morphology scan as a routine component of their antenatal care. So it's a very good opportunity to look at the cervical length because it's a powerful predictor of spontaneous preterm labor, and a transvaginal approach is the gold standard for measuring the cervical length. It's superior to a transabdominal. And we certainly know that the Australian Society of Ultrasound Medicine recommends universal screening by measurement of the cervical length to be included in all mid-trimester morphology scans. So the management recommendations for a shortened cervix on a morphology scan should prompt a multidisciplinary management strategy, which is basically referring it to the tertiary unit here, which is Canberra Hospital. It will include, involvement of the GPs, the obstetricians. It gets quite complex when it's extreme prematurity. So, when you're looking at cervical incompetence with, cervical dilatation and a length of 4 millimeters in someone who is 23 weeks or 22 weeks, we do have an excellent neonatology team on board, and they present for those particular emergencies. We also have our fetal medicine unit imaging specialists here, so we can sometimes seek a second opinion, particularly if the scan, if it was a transabdominal, if it was done in a small unit. So all women should be referred to an appropriate high-risk antenatal clinic where this management can be sort of considered and looked at and developed. Again, we go to management strategies, which was our conservative approach, as serial cervical length measurements, progesterone for medical and surgical cervical cerclage. So to talk about the conservative approach, a cervical length between 2 and 2.5 centimeters in a low to moderate risk patient, you can actually offer cervical surveillance. And we do that even at the hospital here. So we will generally repeat a transvaginal ultrasound in 1 to 2 weeks. And if the cervix continues to shorten, we will commence vaginal progesterone, or if it's gone from 22 millimeters to 0.9 or 9 millimeters, then we'll certainly be looking at a rescue cervical transvaginal cervical cerclage. There is no clinical benefit if we opt, if we get someone from the first group who have a cervical length of 20 millimeters, and we continue to do serial scans. So we might do them more frequent to start with, once a week, and then if it's stable on 3 or 4 scans, we will move to every second week or every 2 weeks, and then we'll stop at 26 weeks. Progesterone supplementation, again, there's been a growing body of evidence supporting the benefits of vaginal progesterone for the shortened cervix in an otherwise low-risk pregnancy. If a woman at low risk, say a primate, is found to have a cervical length of 20 to 25, it is appropriate to recommend cervical surveillance or vaginal progesterone. But even if we commence them on vaginal progesterone pessaries, ongoing cervical surveillance is still required for this subset of women until viability is reached, which is 24 weeks. The vaginal progesterone pessaries are safe to use for the mum and the baby. They have a few systemic side effects, but they're fairly minor, so that, the commonly reported are dizziness and headaches, vaginal irritation, sometimes a little bit of vaginal spotting happens with those too. The surgical intervention available is a cervical cerclage, and that is a procedure that involves we use a non-absorbable suture, so either mercilin or nylon. I myself use nylon, and that's the recent evidence supports nylon to be less irritating, easier to move, but the outcomes are pretty much the same. And there are, again, there's, you might look at doing an elective pre-pregnancy cervical cerclage, particularly for those that have been diagnosed with cervical incompetence and have some repetitive poor outcomes in terms of mid-trimester losses. So we may do a transvaginal Shirodka suture, which is basically a purse string suture around the cervix. There's also a subset of patients who would require a laparoscopic abdominal cerclage where they have had repetitive cone biopsies and there's barely any cervix left. So there's no room for us to do that vaginally. And then I would do that laparoscopically, place that prior to pregnancy. When undertaken before 24 weeks gestation, there is good evidence that there is a risk reduction in preterm birth. Past 24, there's no evidence that it's going to work. That's why we stop at 24 weeks. And again, we'll just touch base on the risk factors for preterm birth. Prior history of preterm birth and mid-trimester losses is that largely, and a prior history of a cone biopsy in particular determines whether or not we're going to actually place an elective suture. Congenital uterine malformations, bicornuate uterus, septate, and uterus didelphys are also recognized risk factors, as we mentioned earlier on. So the rescue cerclage, the emergency is considered in the setting of a woman presenting with pre-viability, so that's up to 23 weeks and 6 days, with slight cervical dilatation, so 1 to 2 centimeters, or if she was, placed on progesterone and then with monitoring the cervix progressively starts to rapidly shorten. So that's a rescue cerclage. So, and the last slide of the presentation is just key points for us to kind of recap on and remember. A cervical length should be confirmed using a standardized technique, which is a transvaginal and rather than a transabdominal. Multidisciplinary team approach should be initiated with involvement of the obstetrician, neonatologist, to discuss obviously the risks of preterm birth. If the patient was found to have a short cervix, repeat transvaginal ultrasound for cervical length measurements in 1 to 2 weeks, and consider commencing progesterone if it starts to shorten. Progesterone should be offered for prevention of preterm birth in women at low risk if the cervical length is below 20 millimeters at 18 to 22 weeks gestation. For women deemed to be high risk, cervical cerclage should be considered if there is cervical dilatation prior to viability, or if the cervix continues to shorten during surveillance. Thank you, Leonie.
That's great. Thanks. We've got a couple of questions. That was really good. One question is, how urgent is the initiation of progesterone? So if a person has an ultrasound late in the week, can the initiation wait until the next week?
Well, I suppose the answer is yes, but obviously the sooner the better. It does take progesterone sort of 5 to 7 days to reach therapeutic levels and to start having an effect. But yeah, certainly if a week later, that's not the end of the world. Yeah.
Yep. And you talked about cone biopsies, but another question was, is LETS a risk factor for a shortened cervix?
Yes, it is. So previously we used to think that repetitive LETS procedures or a LETS procedure per se has an accumulative risk, meaning you've had more than one. But now there's growing evidence that even one LETS is actually a recognized risk factor for cervical incompetence. So, yeah.
Wow, that's
yeah.
incredible. Yeah.
Yeah. Well, the LETS equally only the LETS. It depends on what type of LETS. So there are 3 different types. There's type 1, 2, and 3, and that is in reference to the size of the LETS that was done. So the bigger the lesion, the bigger your LETS, the more surgical specimen is retrieved from the cervix, the higher your risk is of cervical incompetence.
Right. Is there any risk of infection with the cervical cerclage?
Yeah, so the counseling is quite complex from a neonatal perspective, and also the associated risks that comes with it. Yes, there is. There's a small risk. They do, obviously it's done either under a spinal or a general anesthetic in a aseptic technique. In those patients, we do give them intraoperative antibiotics. We do not recommend postoperative antibiotics, because the evidence is if you give it intraoperatively, then that's sufficient enough to reduce the risk of infection. There's also a risk of rupturing the membranes. So it depends how, what the particular situation is. If the cervix is dilated, sometimes you have bulging membranes. So you do a speculum and you see membranes and, parts of the fetus are actually there. So that's when you have an hourglass appearance of a cervix. And there are particular techniques we use to reduce the membranes back into, or the sac into the uterus, and then I do that. I place a Foley's catheter or a urology soft tip catheter and inflate it a little, push the products back in so I can get a better cervical length and then reflect the bladder. And the principle is to put a suture as high as you can, as close to the bladder as you can. So there's a risk of rupturing the membranes, a risk of infection, risk of inducing labor, I suppose. But then when you look at, you're facing cervical incompetence with a cervix that's less than half a centimeter or a centimeter, there's a good 70 to 75% chance that a mid-trimester loss will occur within 2 weeks' time. So pros and cons to this.
Yeah. And what happens to the suture during labor?
So we remove it.
Yeah.
Yeah. So as I said, there are two types. There's the Mercilin, which is more like a net. It's quite a bulky stitch. And there's a nylon stitch. And I prefer the nylon because it's easier to pass. Now, the Mercilin can sometimes rip through a very fragile cervix, and it's also harder to remove. So we try and remove them in birthing suite when they present in labor. But a lot of times we have to take them to theatre and do it under a general or a spinal anesthetic or happy situation.
Yeah. Another question: how would you counsel a high risk or preterm birth or short cervix, a woman who asks if she could continue sexual activity? So
yeah, so good question, and that's kind of evolved over time. 10 years ago, when we had someone with cervical incompetence and substantial, significant cervical shortening, what we did to them was terrible. So those will be bedridden. They will have calf compressors on. They will be anticoagulated, and they would have a catheter, and they would sit there for weeks and weeks. It was awful. And then there was some research done into that. The composite outcomes didn't really change. So those patients were there, were bedridden for weeks, and if not months. And they were again advised against sexual activity. And then now we've changed it. So there's no evidence to support bed rest. So we don't have them resting with short cervix. And they don't need to be admitted. It's only in cases of extreme prematurity. We keep them in a few days after we put a cervical suture in. But I still say avoid sexual activity here because there's not a great deal of research about that, aside from I think 2 or 3 studies, which advocates that there might be some triggers that are coming from the semen. So yeah, particularly prostaglandins.
We'll wrap it up pretty soon. So if anyone's got any further burning questions, type them into the Q&A question. One more question is, so what about people who have cervical lengths that's between 25 and 30 millimeters? I know you have to have an cutoff at some stage. Are they fine not to be monitored?
Yes, they are. If they're low risk patients, but if they're patients who are moderate to high risk, then they should be monitored.
Yeah. And it strikes me that, in all these situations, if you're giving progesterone or if you're monitoring, you have to keep on monitoring, don't you? You can't just kind of intervene and then kind of say, see you later. So after 26 weeks, obviously you were saying you can kind of relax a bit, but.
Yeah, no. So if you put a cervical cerclage in, we don't monitor.
Right.
Yeah. You don't need that. You don't need scans. You put a suture in, that's that. But if you want progesterone, then you do. Yeah, you just want to keep an eye on the cervical length. Why? Because sometimes the progesterone doesn't work and you need to put a stitch in. But once you put a cervical suture in, then you shouldn't be doing repeat ultrasounds.
Okay, great. Okay, well, I think that's it for the night. That was very interesting. There's a lot of really useful GP information there. That one thing, I guess, is always check the cervical length on the ultrasound. And if you don't have a cervical length, find out what it is. Keep an eye on the PAP-A. Look for reasons to give aspirin and calcium. Calcium is a low-risk intervention. And all the BMI and gestational diabetes screening. So that was really very useful for GPs. So thank you very much for that. So we'll wrap it up. So thank you very much, Dr. Adham. We will be posting the video of the talk on the Capital Health Network YouTube page. And there's questions about the date of your next webinar, Dr. Adham. There's another GP event on that night, so we can chat and see if you you want to reschedule it. So we've had a couple of people mention that. We will send out all attendees a certificate of attendance so they can self-report their CPD hours onto their CPD home. If you'd like Capital Health Network to do it, please send us your evaluation survey, which Kanal will send out to you, and also send us your RACGP number. So far, our next webinar will be Dr. Adham talking about the endometriosis pelvic pain update. That's scheduled for the 14th of September, but people have been pointing out there's the ACT Health GP Forum event on that night. So maybe we might chat about maybe shifting that to another night.
Sure.
Yep. Okay, great. Okay. Yep. Thank you very much, everyone, and have a good night. Thanks.
Bye.